Hello everyone. So I'm Dr. Tushar Mehta. I'm an orthopedic surgeon and a faculty of orthopedics for the undergraduates as well as the postgraduate residents of orthopedics. I'm sure you must have seen the first video of this series called as OPVS, the Orthopedics Practical Video Series. The first video is already out on YouTube and on my website. That was basically on this topic, or you can say one of the frequently asked questions in Viva, that why metaphysis is the most common site for osteomyelitis. Now, in that effort, I am today coming up with the second video in that series of OPVS. This is about a topic called as transient synovitis of the hip. Well, first let me just prepare some picture for all of you. If you have attended my lecture, I'm sure you guys must be aware of something which is called as a limp. I talk about limp, I demonstrate limp, and then I tell you that there are certain important causes, common causes of limp, out of which septic arthritis is a very important cause, then Perthes disease is a very important cause. Today, I want all of you to understand and to see and to know and to remember this, that the most common cause of a limping child is a topic that we're going to discuss right now: transient synovitis of the hip. Again, before I move ahead, I would like to give you a typical picture. OPD. Next patient, please. Yes, sir, tell me. Doctor, actually, I'm here to talk about my son. Okay, boys more commonly involved. What is the age? Doctor, 7 years, 8 years, 10 years, 11 years. Okay, fine. Tell me. Doctor, he has pain in the hip. The first presentation is always pain in the hip, particularly one hip. Unilateral hip pain. It's usually never bilateral. Okay, anything apart from that? Yes, doctor. We have actually been consulting another doctor for last 1 week. So he started complaining of pain in the hip. We went to another doctor. He did a thorough examination and he told us that he could not see any significant problem in the range of the movement. But yes, doctor, we have noted that for last couple of days, not only he is complaining of pain in the hip, but whenever he makes an attempt to walk, he always is limping. We got certain blood markers done. Except for mild raise in ESR, we could not see anything, and then doctor told us that it is some sort of an infection or inflammation of the hip. So we got a little confused, so we came to you. I said, don't worry, first I'll give you the topic, and then probably I can explain every sign and symptom that we have in the clinical story that we have just discussed. Transient, for a very brief period of time. Synovitis, inflammation of the synovium. We all know synovium is a very, very important layer because it makes an undersheath of the structure called as capsule. So we are talking about transient synovitis of the hip. First thing that I want all of you to understand is that it's a self-limiting condition. I would say that yes, we do play a role. We give antibiotics, we give anti-inflammatories. There are other things also we advise, like bed rest and all. But still, I would like to tell you, I would like to counsel. I always counsel the parents in my OPD also whenever I come to a conclusion of transient synovitis, that it is a self-limiting disorder. It's a self-limiting inflammation of the synovial layer of the hip joint, which comes on its own, settles on its own, and then goes on its own. But yes, it is the most common cause of acute hip pain. It is the most common cause of a limping child. Usually the age group is around 3 to 10 years of age. I hope you remember I told you in my clinical story, boys are more commonly involved. So definitely it is more commonly seen in boys. Males are more commonly involved. Now, as far as the etiology is concerned, still nobody is clear about the etiology, but definitely we'll talk about some certain important facts. Before that, let's finish the statistics. So I told you it is the most common cause of a painful hip. It is the most common cause of a limping child. Bilaterality is very, very rare. Unilaterality is common. In that unilaterality, I'll be very honest in telling you that there is no left and right. There is no preponderance which has been observed. It's just that, okay, boys are more commonly involved. Now, let me make certain things very clear to you before I go ahead to discuss this slide. My professor used to say that transient synovitis of hip is actually a diagnosis of exclusion. A child coming to you with a unilateral hip pain going up to the groin, going up to the knee, going up to the thigh with slight amount of fever. You rule out every damn thing and then you come on to a diagnosis कि चलो ये नहीं है, ये नहीं है, ये नहीं है, तो ये होगा, transient synovitis of hip होगा. So any acute onset of unilateral or monoarticular hip pain along with a limping child without any systemic signs of illness That is transient synovitis. Now, there are many names given to transient synovitis of hip. There are many names given to it. Some people call it toxic synovitis, some people call it irritable hip syndrome, some people call it observational hip, some people call it transitory coccitis, some people call it coccitis serosa. I mean, what I used to learn as a postgraduate resident is the transient synovitis of hip, also called as observational hip because treatment is purely observation, also called as irritable hip because the structures are irritated, or the toxic synovitis. These three terms are important. Now, I have already told you about the transient thing. I've already told you that it is called observational hip because normally you observe for about 1 to 2 weeks. Self-limiting disorder which settles on its own within 1 to 2 weeks. Now, let's move ahead. I totally understand and I totally agree that etiology is unknown, so there is no confusion about that. But still, I would like to tell you that three important things are there. One is trauma, another one is viral infection, third is allergy. Three theories have been postulated कि एक तो trauma हो सकता है, some trauma happened, it resulted into transient synovitis, some viral infection, or maybe some allergy. Now, one thing that I want you to understand, that whatever it is, whether it is trauma or allergy or viral infection, one thing is for sure, that it is going to lead to inflammation of the synovium, which is further going to giving rise to swelling in the synovium, which is going to increase the intra-articular pressure. The pressure inside the joint will increase, just like a typical septic arthritis or stage 1 TB hip. Whatever I've seen in my career, of course that is written in the textbooks also, but I will tell you one thing which I've seen consistently in these people, in these kids, is there is a associated upper respiratory tract infection. The moment you take the history, the mother will tell you he had a non-specific viral pharyngitis. He had a, he's been having recurrent tonsillitis. Some upper respiratory tract infection will be associated in almost in majority of the cases, and there has to be a preceding URTI. Now, I have given you a conclusion about the etiology. ठीक है, viral हो सकता है, allergy हो सकता है, trauma हो सकता है, and whatever it is, it will lead to swelling of the joint. It will lead to increase in the intra-articular pressure. There is a significant association with an upper respiratory tract infection, but there is one more thing that I want you to understand is, I personally feel, and this is my assumption, whatever I have read, I have made this assumption out of that, that we should not call it as an infection of the joint. What I personally feel, because there's no frank pus. In transient synovitis of the hip, you don't see a frank flowing pus. So what I personally feel and what I personally think is that it should not be labeled as a pyogenic infection. It should not be labeled as an infection. It should be called a very non-specific, non-pyogenic inflammation. And that is what I've written here in the bold and red also, that if at all a biopsy is taken from the synovium, there's always a non-specific, non-pyogenic inflammation which is observed rather than a frank infection. We've already spoken about the clinical presentation. Boys are more commonly involved as compared to girls. Monoarticular problem, usually never bilateral. Age group is anywhere between 3 to 10, 3 to 12, 3 to 15. But yes, there is an acute onset. Yes, there is no systemic signs of illness. Yes, there is a pain in the hip which is radiating to groin and knee and thigh. But yes, there is a limping gait. As I've already discussed, it is the most common cause of a limping child or even a painful hip in a child. Different people have different threshold of the pain. I'm sure we all are intelligent enough to understand that. You have a different threshold, I have a different threshold. Majority of the children who suffer from this disease, transient synovitis of the hip, they just complain of a pain in the hip radiating to groin, thigh and knee, and apart from that they complain of a limping gait. Technically, normally in neuropathy, you will never see them complaining of any problem in their mobility. I'll give an example. Even when you will make them lie down supine on the couch, and when you will examine those kids, you will see that okay, flexion, extension, abduction, adduction, rotation, every movement is normal. But there will be one thing very striking to you, that movements are usually restricted at extremes. The whole abduction, while the child is lying down supine, whole abduction is possible, normal, fine, comfortable, but at the extreme, in the last 5 to 10 degree, you will see this, you will see a slight tension on the face of the child, that he doesn't want you to do that. Certain cases which present very early, like on the day 2 or day 3, their hip would automatically be in a position of flexion, abduction, and external rotation, because I'm sure by now you must have understood if you attended the lecture. I've already told you that whenever there's an inflammation of synovium, that usually leads to increase in the intra-articular pressure, which leads to capsular distension, which leads to a lot of pain, which leads to a lot of spasm, and a human body has a tendency to take the joint into the most comfortable position, and the most comfortable position of the hip joint, as we have discussed in our lectures previously also, that is flexion, abduction, and external rotation. So it happens, it doesn't happen that commonly, but yes, in an acute stage, flexion, abduction, external rotation might be the presentation of the hip, but in majority of the cases, there is no other issue except for, the movement is restricted at extremes. Diagnosis. My dear friends, I've already told you that diagnosis is entirely by exclusion. You rule out trauma, you rule out some developmental disorder, you rule out some pediatric disorder, you rule out some vascular disorder, you rule out some infective disorder. When you rule out everything, there's only one thing which is left: irritable hip syndrome, observational hip. Now, I would say diagnosis is entirely by exclusion, and diagnosis is entirely clinical. You'll ask me, sir, what about the blood counts? I will tell you about that, but they don't matter much. So, what about the x ray? It will show you something which I will show you as well, but it is not going to matter that much. What about USG? USG will help to differentiate it from other condition, not diagnose. MRI, very important for diagnosis. Let's talk about the investigation now. First of all, lab investigations. My dear student, as far as lab investigations are concerned, you will see almost everything with a normal limit except for just mild raise in ESR. ESR will be like, normally it is less than 20-25, so ESR will be like 45, 48, 49, 51, something like that. So except for mild raise in the ESR, remaining everything, TLC, DLC, everything will be absolutely normal. So there won't be any significant issue in that. Now after that, I'll talk about an X-ray. Again, I would like to tell you that X-rays are not very important for inclusion of the diagnosis. What max you can see on an X-ray? You can see widening of the joint space. You can see widening of the joint space, particularly widening of the medial joint space. I'm sure you can appreciate the joint space here, and now you can appreciate the joint space here. So overall also, I'm sure you can very well appreciate that joint space has been widened. You can very well appreciate. Simple enough. There's an increase in the intra-articular pressure, there's an increase in the capsular volume, so joint space will be widened. So just for a mild raise in ESR, rest all counts are normal, not diagnostic. X-ray shows elevated increase in the medial joint space, again not very diagnostic. The third step, what they say is that USG is very important. I can very well vouch for the fact that USG is better than an X-ray, because in USG you can confirm a classical effusion inside the joint. आप बता सकते हो कि ठीक है इल्लोसवास में this border, this part, there's a presence of some amount of fluid there, so there is some mild effusion there. Maybe you can even aspirate if you feel that it is possible to do that. If it is in the significant quantity, you can aspirate, because with aspiration you'll be able to rule out whether it is just a fluid or a pus, because you have to rule out septic arthritis also. But ultimately everything goes with the MRI. Extremely sensitive, is the thing which is going to represent the pathology crystal clear to all of you is MRI. And aspiration, I've already told you that you have to rule out septic, then only you will do that. What are the common differential diagnoses? Perthes disease, slipped capital femoral epiphysis, septic arthritis, and certain rheumatological disorder. First of all, Perthes disease. Now in Perthes disease, the symptoms will have a longer history, like 3 weeks, 4 weeks, 5 weeks plus. In Perthes, there are classical clinical X-ray, there are classical radiological features. Perthes में X-ray will clearly show you a fragmentation of the head, crescent sign, gaze sign, sagging rope sign, damage of the osteochondral part of the head of the femur, as Perthes is an osteochondritis. We all are aware of that. So just by looking at an X-ray, I can rule out Perthes. SCFE, first of all, age 14 to 17, then body build of the patient, and then of course X-ray signs of SCFE, Trithovan sign. Septic arthritis, do you expect that septic arthritis will have just a mild raise in ESR with other normal counts? No. TLC will be 20,000 plus, neutral will be 95% plus, ESR will be 100 plus. Understand my point? Similarly, when we talk about rheumatological disorder, there will be systemic features, there will be many other systems which will be involved. How do you manage? See, guys, when I started the topic, somewhere down the line, you will also realize that I told you the management there and then observational hip. So there's a very old saying about transient synovitis of the hip that the job of an orthopedic surgeon is very simple: observe till the disease cures itself. So your ideal treatment is to keep a watch, wait and watch. Call the patient for regular follow-up. But while you send the patient back home from your OPD after confirming the diagnosis of transient synovitis of the hip, the first thing that you have to tell the family is complete, absolute, strict bed rest. If you'll ask me, that you can talk to me about multiple ways of treating transient synovitis. I can tell you only one thing: patience by the parents and rest by the patient. Patient आराम करे और जो उसके माँ बाप हैं वो हौसला रखें. Rest is the best. So absolute strict non-bed bearing. You have to get up from the bed only for nature's call and probably to eat something. You have to decrease the activity of the joint. The child, forget about playing and walking and going to the loo. The child should not have any activity, because the more amount of rest will give you a better outcome. Traction, I'll be very honest. Some people say it should not be given. See, it's very simple as far as I'm concerned. I'm not a big fan of traction. I never advocate traction for any reason. It is just going to aggravate the problem, that's all. Joint aspiration, if you feel on an EUSG there's a significant collection and you have to rule out septic arthritis, then maybe you can do that. But again, I'll come to the point that majority of the symptoms resolve within few days. You can allow the wet bearing only once the swelling disappears. Very good outcome. Bloody, the name itself says transient synovitis of hip. Transient, it is there for just couple of days to couple of weeks. Observational hip, where no rocket science is involved in your treatment, just you have to observe, that's all. Irritable hip syndrome, the hip is just irritated and the only thing which is required is give it time to settle down. So it has a fairly good prognosis, but the problem is recurrence. So I tell usually the mothers that next time you have to ensure that your son, a 9-year-old son, he should not be, he should be discouraged to eat ice cream and all these ice based things or excessively cold drinks, because anything like ठंडा पी लिया, cool drink पी लिया, या आइसक्रीम ले लिया, या बर्फ खा ली, so that is going to precipitate or aggravate an episode of upper respiratory tract infection. And it is believed that URTI will sooner or later down the line will again provoke an episode of transient synovitis of hip, which is going to give him a lot of hip pain, and not only hip pain but also a limping gait, which is going to alter his daily activity, might stop him going for play or maybe school or maybe studies or whatever. So this is the way how I communicate with the parents, and I wanted to keep this topic essentially entirely clinical. So therefore, I started the topic with a kind of a clinical picture where I told you that parents are there and they come with a child, and there is a unilaterality which is involved, there's a hip pain which is involved, there's a limping gait which is involved, it is a diagnosis by exclusion, there's a mild raise in ESR, otherwise counts are absolutely normal, X-ray has nothing much to do, USG has nothing much to do, except for the fact when it is confused with septic arthritis, and MRI is important, and we have spoken about the management also. So I do hope that you can get benefited from this video in this series called as OPVS, Orthopedics Practical Video Series, where we discuss not only certain important long cases but short cases, but theory questions, and as well as certain implants, instruments and spotters which are important for UG as well as PG point of view. So thank you so much, and look forward to the third video in this series. Stay tuned and subscribe to the YouTube channel and the website link that has been shared. So thank you so much, all the best, good night, and take care everyone. Bye bye.